changes from doing the skull, which is 2 inches above the glabella. We know that.
Is it
But
30?
when we do it, actually, 30 degrees caudal angulation. When we do it for facial bones, we're actually looking at the zygomatic arches. What typically has happened is somebody got punched in the face, and they've blown out that portion of the orbit, which actually happens to be our cheekbones. Okay? So we do this Towns view, but we actually set it up at the glabella instead of above the glabella for this. When you look at the image in your textbook, you're going to notice it looks kind of like an alien. It actually shows these kind of really elongated face, and now we're seeing these zygomatic arches as they're projected down the face to see whether or not they are actually communicating with each other or they're fractured either laterally. We can't see them superior and inferiorly to it. We actually do a different view for that. And what's that? That's the SMV and or lateral view for that. But in the AP projection, axial projection, we can see whether the fractures happen so that it transfers forward or it transfers back. We need to bring those together. Any questions on that?
Yeah, so you said for facial bones.
We're going to come right to the glabella.
That's the area right between the eyebrows.
It's right. It's between the eyebrows, correct.
Okay.
That's where you.
And it's impossible to distinguish that between the nasion. The nasion should actually be between the eyes, somewhere right there at the bridge of our nose. And the glabella generally is between our eyebrows. For lots of people, there is no real distinguishing property on that. Do your best. I'm not that fixated on it. You'll actually give me the right projection I want for that. The difference for this is you're going to tuck your chin down further even for me. There you go, just like that.
And then
Come right between our eyebrows for me. Is that you'll see, instead of the central ray transferring across the EAM that we did for the original Towns, what were we showing? We're clinoid process out where the foramen magnum comes. Now we're looking at the zygomatic arches. So it's basically just coming right through the zygomatic arches.
Gotcha.
One is coming through the ear hole. The other one's coming across our cheekbones that we're actually projecting for.
so
She
should I
just
drop
needs to
it?
make sure she's mid-sagittally set up. Go ahead for me. I'm sorry, I keep
Should I drop
interrupting
it
you.
a little bit? See how?
All you need to do is make sure that she stays in a tucked position for her. She
Okay.
ends up having to create a real tucking or flexion in terms of creating an OML line. Others not as much, but for her, she definitely has to.
And you're still going with the OML line instead of the.
Correct. It's always the OML. It'll never change in terms of all projections. I know I heard your voice. I just
Yeah.
don't see you.
Yeah.
Nothing will ever change in terms of the IOML or the OML. For the IOML, it's SMV and the lateral.
That's it. Okay.
Everything else is OML for it. I'm lying to you a little bit because I'm going to show you one more view after we do this. But this is the Towns for facial bones. You can tell the difference because we're looking at the zygomatic arches for this projection. The previous one we were looking to see the clinoid process projected through the foramen magnum. Cool? Go ahead and
So, I'm
relax
sorry,
after
do we
that.
need to drop it a little bit there? Since our.
Just right between your eyebrows, the best you
Okay, so
can.
it was, okay.
The best you
So
can.
a little bit off then.
What I would look for is whether or not it's coming across the
Chin up?
zygomatic
Yeah,
arches.
okay.
And we're just
Okay.
seeing it today. When you do it, we'll go over it. You'll get it. You're all doing really well. It's clear at the end of the semester you all have a real command of using the device. Mr. Hollis, remember, doesn't know how to fucking use the device clearly, so don't let me touch the equipment while you're working with it. I just bring it out of detent, screw it up. It's not worth playing that game with me. Good job. I can't see whether she's mid-sagittal, but you are hitting your
Yeah,
right spot.
yeah, the thing is a little bit
Sounds-
tight right here, the chair.
This is
Okay.
Towns.
Sounds facial.
This is
As
Towns.
you like to say, downtown. Don't you usually sing a little song or something for it? Come on, Latino, let's hear the song.
I don't know what song.
Can you show the first one you showed?
The first one was a lateral.
Can you show that one again?
I can.
Okay.
She can show me, actually.
Okay.
We'll do it
Okay.
together. What changed with this lateral as opposed to the previous lateral? The skull lateral is what? 2 inches above the EAM, right?
Yep.
This is
Okay.
actually the lateral for
Just
facial
right
bones,
there.
so we would want to be right there in the zygomatic arch.
On the
You're right, this is
zygomatic
here.
arch.
So at the EAM?
It's between the EAM and the outer canthus, so somewhere between those two, along this bone here, which we call zygomatic arch.
Okay. So you don't center at the IOML and the EAM anymore for this one, or you
We'll
do?
bring
You do. This is
Okay.
still an IOML because it's a lateral. Laterals will always be IOML. SMDs will always be
Chin down
an
for me.
IOML. Everything else will be OML.
I'm gonna bring you in like that.
So the difference
making
is
all the right motions at it. She's going to make some adjustments. Watch what she does.
Let's see if I can.
You're right. Good job. Going to make sure that she's
She's
taking the mid-sagittal plane, making sure it's parallel to the image receptor. Again, for the criteria, if you don't have that right, you'll actually won't have the superimposition of both the orbits and what we call the sella tursicas, actually, to read the criteria. I'm not worried about that. It's your job to read the chapters for me.
more likely like that, am I right? A little open the top. Let me see.
See how her
Chin
cheek
down a
needs
little
to come
bit?
out just
Chin
slightly?
down?
Yep, drop your chin and then come out here a little bit. Sorry, I'm pushing on your face so much. See the difference? I want that plane to be parallel with this. Light on. She wants to see a picture of it. I think that's why she wanted you to do it again.
Oh yeah, no,
You got it?
It's just,
I got it. Got it.
Good. Thank you very much. Sorry for both of you.
no worries.
Cool.
Okay.
You're doing great.
So it's in the middle.
Excuse me?
So it's not like okay. So you're saying it's close.
It's somewhere halfway between the outer canthus and that EAM.
Okay.
Now, is it perfect? Probably not. Does it have to be perfect? Probably not. You'll get better and better at it. Here's something else we're going to do. Go ahead and turn around facing the image receptor. It's called a canthial meatal projection. Some of you call it the waters, which is what we usually do. So we take the mental point and we bring it up to the point where it actually comes perpendicular to the image receptor from the EAM. So she's going
You're right here.
to way too much. See how the difference is?
Okay.
We're here.
Chin.
If we left it here, we should be going through the EAM and exiting the chin, which is the mental point, as we call it here.
Okay.
But in fact, go ahead and turn the light on for me. We exit here, the acanthion. So come up higher with the image receptor. Sure. Right above, between the base of the nose and the lip, we exit there for it. A little higher for me?
Oh, nose.
The base
Not
of
that
the
much
nose.
higher, just a slight. Back down again.
Just right here.
This is called the Waters method. It's very simple. You'll see these more often than anything else, because as I said, we do these for doing a MRI case we're looking for metal.
turn the light
The way we'll handle that is the patient will be asked to look up during this projection. We'll change the image receptor, then we'll have them look down. If there's a piece of metal in the eye, it'll actually transfer across as a patent a portion of the image. It's a little fleck. You rarely see it, but when you see it, you'll see it. And it's not your job to read it, it's just to do that. Look up, look down. For us, we do this for facial bones for the same reason people get punched in the face. It's just, or they go through a windshield of a car, or they fall on their face, they got a huge contusion, like when they get older. Fairly simple projection for that.
So you
We
said-
also do it for something that we're going to learn come Wednesday, which is for sinuses. The only difference between this, facial bone, and sinuses is although we do this projection, we also do one more. And I just want to show you in a continuum about why we're doing all this. Lift your chin right there, up against the image receptor. She's exiting a canthion. Drop your chin slightly. There you go. I'm sorry I'm touching your face so much. So that's the waters. When we do the next view, we can actually project the maxillary sinuses through the mouth, through the hard palate, by having the patient just drop their chin open and go, and then we make that projection. If we're having a problem seeing the maxillary sinuses, we can project them through the mouth, and this is one of the ways we do that. Go ahead and relax. So it's as simple as the waters and the open mouth waters, or modified waters. That is our sinus series in terms of waters. Any questions on that? I know none of you have gotten a chance to do it. You may have seen it actually clinically, because they are done for those of you who have an MRI center outside. You can figure it?
Yeah. So
Go ahead and relax. I know I'm working the hell out of you. You're a great patient.
So for the waters, for the practical, are you gonna have us do a projection with them looking up and looking down?
No.
Okay.
A totally different view, and that's a great question. I just want you to know that when you're actually going to do, should you actually get in a position to do waters, and it's to determine whether there's metal in the orbit, that's how we do it. So that when you attack it for the technologist, you know what your role is, and they'll understand that you understand and part of the education system. For my practical, which I know that's always every question everybody really wants to know, is like, I don't really want to know anything other than what's on the practical, Mr. Hollister. You could just get to that. That would work really well for me.
I wasn't saying that, but
But I totally get it. I mean, I've been a student, and I'm actually now forced to try to regurgitate some pieces of it. We will, once again, be very clear about what it is we're looking for. If it's a skull, it'll be what we were just working on Wednesday. Basically, all those views. Where are the projections? And as I continue to say, and I'll continue to say all day long, you only have to worry about the IOML, 7 degrees difference, and the OML when we do the laterals, any lateral. When we do an SMV, any SMV, doesn't matter what we're doing it for. All the rest of them, in general, for the skull work, is OML. We're seeing a change now, right? AML, we're now looking at waters. It's just a different view. We stopped doing orbits. I used to have to teach orbits. There were a bunch. It was a very complicated image with 2-inch square. Students suffered through it, and then they never saw it again. For orbits, we're actually doing them in CT. I'm not teaching them anymore. I won't be doing a practical on you for it. It's called a tripod. Should you ever have to do something in the middle of the night, remember to put the nose, the forehead, and the cheekbone together onto the image receptor and place it against the image receptor for the patient. They'll usually be drunk, so they'll be thrilled to have you doing this to them, usually. So they're looking at the image receptor and shoot them right above the EAM behind the head with a 4-inch collimation on it, and you'll get what you're looking for. The emergency room physician won't be able to read it, but you'll have gotten your image so that in the morning when the radiologists come on, they'll actually know that you know what you're doing. To answer that, next question. Again, for the skull, we all saw what it is. We'll practice some more of that. Today, we're looking at the facial bones. There's not a big difference in the facial bones because I basically went over the ones that I'm particularly interested in. Towns change and the, what? Lateral change. Great. The only thing I haven't shown you yet, which we'll do, I'm going to find another victim because I know you want to see a little bit of what's going on here, is the nasal bones. Now, the nasal bones themselves are an easy image to do. We treat them like we're doing a finger because the bone that's actually within the nasal portion of it, collimated down, is about the size of our pinky. Actually, it's even smaller, but we use the same technique, about 60 at 1, sometimes 55 at 2, depending on where you're working on it. And we do it without the Bucky device. So we figure out a way to place the image receptor on tabletop, so to speak, but upright. Because if the patient's needs to do a nasal series, what's happened? Again, their face is not something solid. Hopefully it isn't one of somebody's fist, but oftentimes it is. We used to have upright capturers for this, but again, somebody liked it and stole it. I don't even know why. And then I had another student build it out of metal, and again, it was stolen. So I've kind of given up on the idea of trying to create something that will do it. What you'll do is you'll tape it to the image receptor, and there's a real challenge around it, but you'll get good about actually getting the tape together and putting it up there. Many of your devices will allow you to actually put it in a hanging Bucky without utilizing the Bucky device. What we can do in devices that aren't captured to the wall, this is the problem with our lab, right, is that this device will only go another foot outside of the central ray of this, right? You'll find out because you'll struggle with it. Many of you are going to try to do it the way that most techs will do it. You come around the side of it. You don't even have to. So here's the image receptor. If I take it out, it's no longer within the Bucky device. Face is no longer more than 9 centimeters. I don't need a Bucky device for it. The problem is trying to get it to come over far enough laterally. Whoops, watch it run away from me now. This thing hates me. Come here, stay. So that the nose can be here. And we do bilateral. So we set up for the IO mount. I don't know if I'm going to be able to do myself, actually. I won't be able to do myself. Almost. IOML, right? The base of the orbit to here. And I just put my nose right there, and then I collimate really down on it, really tightly. So I'm only showing my own nose. And then we take a finger technique to it. And then we do the reverse, because it's always bilateral. But on your practical, you'll only do one view of it. So that's the concept. I have a little too tightly collimated, but barely. Doesn't take much at all. Let's see if we get this right. I'm gonna see if I can use his vise. It's hard to do because it won't go far enough over, sorry. I'm clear over here. I'm gonna create magnification from it. So she's gonna put her feet there. I'm sorry, I keep pushing on you. I'm gonna push her laterally. I'm gonna drop the center ray to the IOML line, or actually determine where the IOML line is, which is what I'm gonna do to her right here, right there. Turn the light on for me, and then I'm gonna push her back. And I'm just gonna capture right there at the bridge of the nose, her nose. Right there. That's a left lateral for the nasal bones. If I drop the central ray, it'll be at the IOML that I'm setting her up, and then I'm bringing it up to the bridge of the nose.
Okay.
Go ahead and relax for me. Thank you. So I was able to do her with the right. I'm not sure I'll be able to get the left. You're welcome to try it and or take it to the Bucky device, and you'll have better range with it. Any questions on that?
So tape the IR to the Bucky.
Yeah, so I'm like combine here.
How come we're not using
We
it?
should have tape. What's that, sir?
How come we're not using the wall bucky instead? When we don't need a grid?
We only use a gridded when we're over 9 centimeters. It's actually a physics rule that should be learned. Probably I should have taught you.
9
In truth,
centimeters.
John should be actually be teaching that piece of it.
I think a centimeter is a centimeter, right?
Well, there's 2.54 centimeters for every inch, so you can do the division. But in terms of any AART examination or anything that we measure you by, it's over 9 centimeters. Therefore, there's a question about when do I need a Bucky? More often than not, it's about a knee, right? How big is that knee? Can I put it on tabletop, or do I need to put it in the Bucky? Anytime it's larger than 9 centimeters, which you'll be able to figure out in your
The
head
part.
over a period of time,
Okay.
we place it in a Bucky device.
Anytime.
Because what happens when we put something in a Bucky device? We're using like 4 times the technique to actually get to the gridded device, and we need cleanup for it. So
Okay.
there are many sites that we don't need extremity-wise. Some knees, even some ankles, and certainly some thighs on smaller people that we don't need the Bucky device for. We tend to not use it on a tib fib. Those are usually tabletop. So we get thick enough beyond the knee on a regular knee, particularly adult male. Some women it gets above 9 centimeters, and I don't have the ruler, but I could show you what 9 centimeters looks like. We'll look at it today. We'll find that ruler. So we don't use Bucky devices on anything less than 9 centimeters, just as a general rule. So what do we have here? We have now facial bones, and we've shown that there's a lateral change. There's a nasal bone change. The nasal bone's not that difficult. It's just getting the image receptor right that's going to be more challenging than anything else. I'll leave that to you. I was successful, God knows how, with Yodi to do it. She was a good champion about it.
Could you theoretically
Risked her
do it-
life and limb to get beyond the image device.
Could you do it laying down theoretically, the nasal bone?
You can. What happens if we put somebody laying down?
The anatomy changes, right?
I'm missing what
The anatomy.
everybody's saying something that's kind of exciting. What was
The
that?
anatomy would kind of change, right?
No, yeah, the anatomy won't change so much that we can't make the diagnosis, but you're kind of a piece of it. Any ideas? I don't know why I'm doing this.
Might be harder to move them.
Could be, yeah, right. Inevitably, when we got people upright, they're able to actually give you help. If you tell them come a little way this way, if they're laying down, what happens when we put patients in supine or prone position?
They can't get up.
They can't get up. That's a part of it.
Would it
What do they do?
magnify?
What's the universalism for you? No matter what you're doing, you put a person on the table. They walked in. They seem perfectly healthy. They get them on the table, and they're dead weight, right? They're like, I can't move. You're like, bitch, you just walked in here, got on the fucking table, and you can't move to your left or right. Oh, no, I can't move. I cannot move for you. I'm so sorry. So at that point, you're like, okay. And so you're dragging them around and wrenching your own back to try to position a patient. If you do facial bones, this is the biggest issue. We're looking for fluid levels, particularly for doing facial bones, because somebody's either gone through a windshield, they've hit something, or somebody's punched them in the face. That means we have edema, and usually blood and sweat, or wet and snot, and a bunch of other stuff moving. It's draining out of their face. We don't want actually to leave them on their back while they're drowning in their own fluids.
Okay.
They won't do it for you, first of all. No one will lay down for you if they're blowing snot and blood out of their face at you, which is usually what's going on. They're also drunk. Lay them on their back. They're going to fall asleep. They're going to aspirate whatever they throw up. They're going to die on the table. They're going to own you and your kitty too at that end of the day kind of moment. So we keep them upright. So if they throw up or they blow snot and blood, it's all over the floor. It's all over your clean scrubs. It's in your face. all those exciting things. This is why you've moved into this glamorous job for $59. Did we decide it was $59 an hour? Somebody last week was trying to tell me 59. 59? Do I hear 59?
Less than that.
Nice.
Less than that.
So that's the plan. But those are
Oh,
it.
they
Don't put
start at
somebody down on their
41.
back if you are, even though
They start at
we
41.
do it for children. So Lapatine's always like, a baby. Let's do a baby. Let's keep a baby. But then oftentimes they change, right? Other questions on that? PAAP are the same. We've noticed that the lateral has changed. We actually added a lateral to it. For the facial bones, we do them, although I've never seen them done professionally. The book would like you to know that we do a Caldwell. I'm not big on in angulations for bones that are involved in the facial bones. And here's my next key to you. When we do the sinuses, we never angle the beam at all because we need to show
The fluid level.
fluid levels. Even though the book is saying, oh, we'll do these angulations. Never happens. If you change an angulation and you're looking at fluids, you can't measure the fluids and determine whether or not they are solid or a mass structure associated with it. So as we move to the sinuses on Wednesday, it'll all be the same views. I also showed you that for the lateral, it's the same view. It's just that we won't angle with a Caldwell, and we won't be doing a Towns for sinuses.
Okay.
Other questions on that before we jump into it? Yes,
So for the facial bone, it's going to be
I could write it on the board for
bilateral,
you.
right? It's going to be both sides.
It is for nasal, but guess what? For my practical, you won't have time to do bilaterally. So I'll only give you one. I can just tell you professionally, when you're doing nasal bones and you're doing the nasal bone, then you'll do them bilateral. You do a right and a left.
So, yeah.
It's
So you're
exciting.
saying that, like, if we were to pull it on the practical, we only have one projection for the
You only get one. If you pull one, it's facial bones, and on there it's nasal,
Gotcha.
it'll be a left or right nasal bone.
Gotcha.
It won't be left and right.
Gotcha.
So far, I did it before because I didn't really want, it tends to be the one that traps people the longest and they're most nervous about doing it. Whatever. Maybe it's because it could be challenging, particularly given the devices we have. If you want to do nasal bones, I think you're going to find it easiest, even though Yodi was really wonderful in terms of the way she helped me with it, is to tape it onto the image receptor. Questions?
How many views is it for the facial?
For facial bones, it's all the same, except for now what we've
For
added
for
is a
the
nasal
four.
bone
Oh.
and the waters. So you just added a nasal bone, waters, and the lateral. Oh, we already have a lateral skull, so it's the same thing. It's just different central ray. Yeah,
Are we only doing the waters PA?
only PA, correct. We're not doing the reverse waters. People do reverse waters. Actually, older techs do reverse waters.
I saw one the other day. That's why I
You saw one?
Yeah, the other day.
No difference. At that point, you enter the acanthon, but make sure the mental meatal point is actually perpendicular to the image receptor. It'll become really obvious to you once we start to do it. I know you're watching me, you're watching your deep. It's not that difficult. You're actually on a roll. You can do the skull work, you can do the facial work. You'll be able to do the sinus series. SMV holds the same. The book will tell you there's differences in the SMV, right? If you read it, one's like 3/4 inch off of, here, away from the EAM. Most people have that much between their EAM and their outer canthus, actually, so there's not a lot of room to do it. We just place it in the middle of it for all of those views. Okay? Any other directions? Why don't you split up again? It makes it easier for you all to practice. I sent